I'm here to introduce the work we've been doing on reducing the number of falls in our trust and the number of falls with serious harm. Falls are devastating, not only for our patients, but also for their families, friends, and for us as their healthcare providers. The most serious physical consequences of falls are things like broken bones or fractures, which may require a further operation in hospital. Other consequences are bleeds on the brain, such as subdural hematomas or traumatic subarachnoid hemorrhages, and these might require referral to a neurosurgical unit. These can lead to death or permanent disability. There are, however, hidden consequences of falling. The fear of falling. I dread to think of the things I used to do when I was little, when I used to climb up trees and have absolutely no fear of falling down again. I can't do that now because I'm too scared of the consequences. This same fear is what stops older people from wanting to get up and about again. That's their fear of falling. The fear of falling leads to increased dependence on family and friends. Reduced mobility means that their muscle strength isn't as good and that their bone strength isn't as good, and this means they're less able to get up and about. Fear of falling leads to social isolation, and this can lead to depression, and so the negative cycle continues. I'd just like to show you this slide. Above the dotted line is independence, and below the dotted line is increasing dependence. As you can see by the green line at the top, that would represent someone like you or me, who goes about our normal business, and then we have a fall. And whilst we might be injured, we basically get up again and carry on as we were. The red line below shows an older person, such as one of our patients that we might look after in hospital. When they have a fall, they have a much more serious consequence, such as a broken bone that we talked about earlier. Their period of recovery, as you can see, takes much, much longer. It might include an operation. It might include a few weeks' stay at a rehabilitation hospital. And in the end, when they do recover, you can see that they have a lower level of function than they did before. And this is what we often see even within our own families, or the tales that patients and their families tell us about. We cannot stop every fall, but we can reduce the number of falls and the number of falls with serious harm. No one person can prevent falls. This is a team effort and a multidisciplinary effort. The rest of this video will show the work that we've been doing at RWT to reduce the number of falls in our trust. It will also show what we plan to do in the future. This is an ongoing effort and an exceptionally important one. No one comes to work to harm our patients, but falls do harm our patients, and we must all do what we can together to prevent them.
C24 is a 27-bedded male renal medical ward.
On C24 we had an average of about 10 falls a month. Staff were good at identifying patients that were at risk of falls, but not necessarily taking action to prevent them. When given the opportunity to do the Falls Collaborative, it was a perfect opportunity to embed the new falls prevention policy to staff and to see what we could do to reduce the number of falls.
We commenced cohorting and tagging a bay on February the 16th, ensuring that there was a member of staff in the bay at all times. This may be a nurse, doctor, somebody from the therapy team, or using our ward receptionist or ward assistant. Since commencing the tagging system, we've only had 10 falls on the ward, compared to the same period of last year of 27, resulting in a decrease of 63% in the number of falls. During the period of time since the tagging commenced, we have gone a period of 18 days without any falls and 2 periods of 14 days without a fall as well.
Ward A8 is a 28-bedded male elderly care ward. We specialise in caring for gentlemen over the age of 65 admitted with any medical condition. On the 12th of December we began tag nursing in 2 bays. Tag nursing is a method for ensuring that high-risk falls patients have continuous nursing presence to try and reduce the risk of patients falling due to lack of supervision. The main point of tagging is that the nurse that is allocated to that bay cannot leave the bay unsupervised. If a person has to go behind a curtain, then they should endeavour to ask another person to tag the bay for them whenever possible. We trialled this in 2 bays for 3 weeks and felt that it was a concept that we could utilise in the other 2 bays on the ward as well. This commenced from the 2nd of January. On the graph you can see a yellow block for that week. Unfortunately, a patient fell and sustained a fracture. When the fall was presented at accountability panel, which includes the chief nurse, it was deemed as avoidable, as the nurse was behind a curtain and the patient had been left unattended by the occupational therapists to complete their documentation out of the bay. As senior sister, it was my responsibility to ensure care delivery and changes were implemented on the ward. My first challenge was to engage all of the multidisciplinary team within the TAG system. This is shown with the blue line.
So as a team, the biggest challenge was that we thought, because we cover the whole hospital, we thought we were going to be stuck in a bay due to the tagging system, but that wasn't the case at all. The team worked together really nicely on the ward, and we find we never stuck actually in a bay, so it's worked really well.
And I think, following on from that, from the sort of medical side, the difficulties were just having a whole culture change. We're not used to being in the bay all the time, even though that sounds silly, we should be, that's where our patients are. But once we got used to the change in the way that we worked and seeing what the benefits were, I think then it was much more easy to get the whole MDT involved.
As you can see, we did have another patient the following week who sustained an injury from a fall. However, this one was deemed as unavoidable, as the patient stated he's got his foot stuck in his bed sheets, and it was something that we could not have predicted would have happened. From utilising the whole of the MDT in the TAG system, we have had a stretch of 28 days with no falls at all, which is a fantastic achievement for an elderly care ward. As we were having a positive impact with the TAG nursing, we felt it was appropriate to implement some other new initiatives from the end of February. During this time, we implemented the Essential Falls box and the grab bags. It sits on our resus trolley, so it's nice and visual for the trust, and it gives you everything that you need in that initial post-fall time, including an algorithm of what to do. So if a patient falls on a night shift and we've got staff on that feel quite anxious and nervous, it tells them step by step what they need to do. And the grab bag is just essentially a bag full of personal hygiene equipment that a nurse can take with the patient to the bathroom, so that they don't have to leave that patient unaccompanied in the bathroom. As well as this, we situated a desk and computer within the bay. All medications were put in the patients' lockers. This meant that we could increase the time nurses, doctors and therapists spent in the bay, and it has had a positive impact on the patients as they have someone that they can speak to at all times.
It's benefited physio as well, because there's always nurses, HCAs or ourselves in the bay, so patients are perhaps being mobilised a bit more because there's always somebody there if the patient needs to go to the toilet, for example.
For our patients, I think they see us there more regularly, and therefore they can always interact with us, and relatives are there at hand as well, so that they can speak to us if needs be.
Yeah, and I would definitely agree with all of those points. I think being in the bay much more often, first of all, you get to see the patients through a much more broad spectrum throughout the day, rather than just one single snapshot on your morning ward round, as well as being able to see the relatives throughout the afternoon. So we've been able to see relatives much more frequently, which I think has definitely improved both the patient and relative experience.
I am positive that we will have another significant stretch of days with no falls in the future, as we have already reduced our falls rate by 54%, and I'm really proud of A8 implementing a new way of working for the benefit of the patients.
It's worked so well here that I'd feel very happy in assisting implementing that in other wards across the hospital.
What I would say is the key is keeping it simple. Many measures will suit some wards but not others. So this is an opportunity to make a difference in your area with the measures that suit you. What I would also say is it has to be a multidisciplinary team approach. We all have a responsibility to reduce the number of falls. So we would welcome you to join the collaborative and roll this out across the organisation. The Falls Collaborative is coming to an area near you very soon.